wasting much time, let us start. Uh, I did promise to Preeta that I'll finish in 45 minutes. Let's see how it goes. Anyway, the idea for the day is, agenda for the day is to cover in brief what is new in terms of diagnosis and treatment as per NTP. May not really be new. There'll be a lot of existing things which we might have covered last year as well. It will be kind of a refresher for many of you and for all the experts here, like Shinobi or Regina or Jalajamani or many others who are there. I think this will be something you all know, but still we'll go through it as a revision and then slightly discuss, a couple of slides on what is happening in other parts of the world in terms of newer things which are different from what we are doing in our country. I'll be discussing some of the issues that we need to consider when we are thinking of ending TB, because if you remember the slogan, as many the others spoke before us, it's like, yes, we can end TB, commit, invest, and deliver. So about ending TB, what are the issues that we're facing, particularly in Kerala, and how well and how badly we are doing with respect to those things. So the global TB scenario still remains very disturbing, and unfortunately, we hold the first place in the world in many of the aspects of TB in terms of incidence. We have almost a third of the world's incidence, mortality, and MDR-TB, which is not a very nice place to be in. I mean, we shouldn't be proud that we are first in this. Definitely, we should be doing better than this, and the numbers should be lower. The numbers are staggering in terms of more than 3 lakh deaths, 28 lakh cases, huge numbers. So, often undergraduate classes, when you ask your undergraduates, how many cases do you think there are every year in India? They talk in terms of 1,000, 2,000, 5,000 and all. And when they hear 28 lakh cases every year, they get shocked. So, the numbers are staggering, and we have a tough task ahead of us. So to get through this, you need diagnosis and treatment, which are the main ways of dealing with the disease. So when it comes to diagnosis, the algorithm has been the same for since I think for the last almost 10 years. So we have smear microscopy and chest X-ray, which remain the main tools at national level, even though the country is now trying to move forward. So you have the same definition of presumptive TB with cough more than 2 weeks, fever more than 2 weeks, significant weight loss, or hemoptysis, or any lesion on X-ray. Certain groups earlier used to get a direct NAT, but these presumptive TB were supposed to go through a chest X-ray and a smear, and then later go through a NAT for finding out rifampicin resistance. But now the country is moving forward, and this is what we are looking at, upfront NAT. So it is expected that every case of presumptive TB in India should get a nucleic acid amplification test as the first test, which helps in early diagnosis, which helps in higher proportion of diagnosis, and also helps in letting you know rifampicin resistance. So because of these advantages, the country is telling people, our doctors like us, that whenever you have a presumptive TB, do a nucleic acid amplification test. We should understand that it's a huge cost to the country. So if you're doing a nucleic acid amplification test per suspect or per person tested, the government is spending almost like 800, 900 rupees. So a lot of money is being spent, and these are lakhs and crores of people being tested, but the government is willing to spend that much of money to ensure that we diagnose more TB and diagnose TB better. When it comes to how well we are performing in terms of diagnosis, you can see that when you take all cases of TB together, we diagnose more than 90% of cases, which is pretty good. So you're looking at 90% case detection, which was the aim at one time, and we are doing better than that. But in terms of drug-resistant TB, MDR-TB, we still are a bit behind, and maybe those numbers needs to go up. Now, these numbers would also have been 90% if all these people were tested with a NAT. So that is not really happening. Now, for testing, you have the two nucleic acid amplification tests, which are readily available. The CBNAT or the Gene Expert, which has been there with us since 2010. So the last 15 years, we've been having these Gene Expert machines. And the TrueNAT, which came later, which is an indigenous technology, which was developed by More Biotechnologies in Goa. This week itself in Delhi, we had a major meeting, national level meeting on innovations. And, many of our youngsters are developing newer and newer technologies. And this was one of the technologies which came from India and now is being used all over the world. So, it's a major success for India that we have developed a world-class technology. And these technologies are available all over. You must have seen this slide last year also. I don't want to go through the numbers. The slide is a bit old, and these numbers are almost double what I'm showing here. But then I just wanted to show that all over the country we have coverage of these tests. So they are available wherever you go. Every district in the country has access to these tests. So that is what I just wanted to highlight on this. And there are various levels of lab which also do other kinds of tests, including cultures, including even whole genome sequencing. There are 5 centers in the government in India which do all that. Now, as I told you earlier, the policy of the government or the desire of the government is that every presumptive TB case, the first test should be the nucleic acid amplification test. So we are moving towards that. And this is from the latest TB India report. So if you look at the latest report, you can see that this is 2024 report, and you should understand that 2024 report will have 2023 data. So this report will have a bit old data. But that at that time in 2023, at the country level, only 21% of the patient had upfront NAT, and Kerala about 40%, much higher than that. But still, even in Kerala, we had a long way to go. Now, many districts in Kerala, for example, Trivandrum district is doing only NAT. Smear microscopy has completely been stopped. So maybe when the 2025 report comes, these numbers would be much better, at least for Kerala. But I think other states of India still have a long way to go in terms of getting this upfront NAT, because their numbers are bigger and the population are bigger. So there are challenges in that aspect. So in terms of diagnostic technologies, these are the technologies which are available to us. So the Gene Expert or the CBNAT, which is one of the best technologies in the world, which allows you to diagnose TB and also allows you to diagnose rifampicin resistant, all within a period of 2 hours. Then you have this newer version of the Gene Expert machine or cartridge called the Gene Expert XDR, which actually allows you to diagnose TB along with resistance to INH, fluoroquinolone, a second-line injectable, and ethionamide. So you will later be discussing some of the newer regimes coming. So desirably, when the new regimes like the BPALM regime come, we should have had this technology, which has been endorsed by the National Technical Expert Group. But because of certain technical issues, this still is not available with us. So this is a technology needed, but still not available, endorsed by the program. Then the TrueNAT is readily available with us, which is similar to CBNAT in terms of giving you TB diagnosis and rifampicin resistance, again within a period of 2 hours. Then you have the line probe assay. We have 2 forms of line probe assay that we use, the first line probe assay and the second line probe assay. First line probe assay gives you resistance to INH, rifampicin, and ethionamide. And the second line probe assay gives you resistance to the fluoroquinolones and second line injectable. So it's important for us to know the resistant pattern to these drugs so that we can design our regimes. And then solid culture slowly is being phased out, even though in the context of non-tuberculous mycobacteria and all, ideally labs should be having solid culture. Unfortunately, many labs in India are stopping solid culture. But liquid culture is readily available, and liquid culture, the MGIT machines in the country, allow you both to look at the viability of the bacteria. So these tests, all these molecular tests, will pick up dead bacteria also. So if you're doing a follow-up, liquid culture is the go-to test. Even in extra-pulmonary TB, yield is highest with liquid culture, and resistant to certain drugs like, for example, bedaquiline, delamanid, petomanid, linezolid, pyrazinamide, and all are currently given by liquid culture, even though technology might allow us to diagnose that with molecular tests in the future. So the Gene Expert TrueNAT machines are available in all districts in Kerala and even at sub-district level. The line probe assay is available in the Trivandrum lab and in the Kozhikode Medical College lab. Liquid culture also in the government is available in the at the Trivandrum IRL and at Kozhikode lab. We should understand that the expert machines are available in many private institutions, and liquid culture, even though sensitivity is not endorsed, liquid culture per se, good quality culture is available in many private hospitals like KIMS in Trivandrum or Aster Medicity and Amrita in Ernakulam or Baby Memorial in Kozhikode. So liquid culture is available, but to do resistance in liquid culture, they are not endorsed. This is not enough. The World Health Organization endorsed a large number of new tests, which include some of the tests which can give INH and rifampicin together, which is the need of our hour. And many of the newer high-end tests like next generation sequencing, targeted next generation sequencing, many machines are available, which will allow us to give a huge range of resistance on molecular basis. So this is a future not come to us so far, but that is something which is promising. We have a new guideline for TB. I'm sure many of you have been trained and many of you have read this guideline. So this has come in 2024. many of the versions, there are multiple versions. So please be careful that you have the latest version. This picture also, I'm not sure whether it's the latest version. Anyway, so the latest version, because each version, there are certain differences in the whole thing. So in this guideline, if you go with it, you have all these presumptive cases who undergo testing. So you do a NAT and maybe expert XDR if it is available, or a line probe assay which is available, so that you have resistance known to INH, rifampicin, fluoroquinolone, and other drugs as required. Now, if the patient has no INH resistance detected, then you will go to this right side of the arm where the patient will be started on the DSTB regime, where while you test with a line probe assay for INH resistance. So rifampicin resistance is not there. So you start the drug sensitive TB regime, and then meanwhile you're waiting for the LPA to give you INH resistance, which can come immediately along with that if you add a XDR cartridge. And once you get INH resistance result, if there is no INH resistance, you continue with the same regime and the patient gets a drug susceptible TB regime, which is a 6-month regime. On the other hand, if INH resistance is detected, then you have a regime for INH resistance called the H monopoly resistance regime, which is a 6 to 9 month regime with again 4 drugs, no intensive phase, no continuation phase, and that may be modified further if there is resistance to any of the drugs in the regime. On the left side of the algorithm, if the patient has MTB detected and rifampicin resistance detected, in today's guideline, if the person is above the age of 14 years, the first regime to be considered is the BPAL-M regime. So, it's a new regime, BPAL-M. We are just introducing it in Kerala. The drugs are already with us and we are introducing it. I think the first case will be started in Thrissur, or may have already been started in Thrissur, and each other place will also slowly be starting this regime. So you have the BPAL-M regime. If the patient satisfies the eligibility criteria, there are many other criteria also. Time doesn't allow me to go in deep into the eligibility criteria and all that. That is for another training. I'm sure that KGMOA or the state TB cell will be arranging that. If the person is not eligible for BPAL-M regime, or if it is less than 14 years, then the first preferred regime is the short MDR regime, which was already there with us, which we have been using readily. And if that patient cannot go into the short MDR TB regime also, then you will go to the longer MDR TB regime. Or for some reason from BPAL-M or from the shorter regime, if you find additional resistance or something and you need to switch regimes, again, you will go to a modified longer MDR regime, all of them containing bedaquiline. So this is in short how you will test and manage your patients. We also have, modules now available on extra-pulmonary TB, the 2023 guideline developed by the All India Institute, and also the standard treatment workflow done by the ICMR. The only problem with this is that because these were formulated by the All India Institute of Medical Sciences, Delhi, they made an assumption that many facilities would be available, which obviously the states do not have. So in the first training at the All India Institute of Medical Science, I was the one who was arguing repeatedly with the AIIMS faculty, and they were all very surprised. They were asking, "Doctor, you come from Kerala. Kerala has the best, best healthcare facilities in the country. If you're saying that you can't do these things in Kerala government service, then which other state will do?" So I said, many of the things for example, for a spinal TB, they want a radiologist guided biopsy from the spine. So not all our government hospitals, or even many of the private hospitals, may not be empowered. There are good interventional radiologists who do all that, but they are not so frequently available. So if you want to do a brain surgery, or many of the other things which these guidelines talk about, contrast, enhanced MRI. So all those things are a technology. Technically, it's available in the private sector in many of the high-end hospitals and some of the high-end government hospitals as well. But they are not readily available across the board in all hospitals, so that, if you really have to go through these guidelines, you'll have to limit the care to a very small number of centers in the country. So having put up the objections, the government of India has now decided to revise these guidelines also. So I think 2025 extra-pulmonary TB guidelines will come. In the meantime, these guidelines can be followed. The guidelines will actually tell you how to evaluate, how to treat. All those things are there in the guideline. So I'll not go into the details of that. The brief summary of management of diagnosis of extra-pulmonary TB is that the symptoms and the presentation will vary on whichever organ system is involved. And the first question we have to ask ourselves is, can I get a tissue? So if you can get a tissue which is readily available, most forms of extrapulmonary, because the commonest form of extrapulmonary TB is lymph node TB, and then the next common form is pleural effusion. both of these, even peripheral hospitals in the government sector can actually take the node out or take a FNAC from the node or a biopsy from the node, or a pleural fluid can be taken out, and that can be tested with NAT, histopathology, and liquid culture if needed. And if the NAT or culture come as MTB detected, then it becomes microbiologically confirmed TB. If only histopathology comes as confirmatory, then you call it clinically diagnosed TB. Of course, a certain proportion of cases, like you might have a case with a tuberculoma, suspected tuberculoma, where your radiologist is very sure that this is tuberculoma. He says this is 100% tuberculoma, and you don't want to subject the patient to a brain surgery, then you might actually make a clinical diagnosis without taking a tissue. Even in the spine, if the MRI is very suggestive and you feel that patient can be tested without testing further, you can actually do it. A clinician is allowed to do it. And again, it is called clinically diagnosed TB. So, even without doing the microbiological test, you can start. But generally, the preferred thing is you have to start with this. And unfortunately for us doctors, the IAS officers think that almost every case should be microbiologically confirmed. So they will be pushing us, and we have to sometimes explain to them that even if I send pleural fluid samples, only 17% of my samples will come positive on NAT. So remaining 83%, even if I have sent the samples, will come as clinically diagnosed TB. But the fact is that for lymph node TB, there is 80% yield. For other forms of TB, there is about 50-60% yield. So these tests do work well, and they should be offered to all patients. We should understand that these tests, if you send to the private sector, will cost a patient around 20,000-25,000 rupees. And these tests are available in our government sector free of cost, and we should give that benefit to our patients. Childhood TB, again, the guideline has been there. Last year also, I discussed the same guideline. So basically, the summary is that there's a lot of emphasis on X-rays. And if you read the IAP guideline, and many pediatricians would be here, including me, so the guideline actually emphasizes on X-rays, and they even give you a lot of suggestions on when you will consider X-ray suggestive of TB or non-specific and X-ray normal and all that. And if at all X-ray is suggestive of TB or you are evaluating for TB, you are supposed to take a gastric aspirate or a induced sputum or expectorate sputum and do a nucleic acid amplification test, and then try to make it microbiologically confirmed. But however, you are also allowed to make a clinical diagnosis if you feel that the child has TB and the test come as negative or not possible. The spectacular change that came in this particular algorithm as compared to the previous one is that there is no Manto anywhere. So, the skin testing has been totally been taken out by the Indian Association of Pediatrics and the NTEP, and you are supposed to be diagnosed based on X-ray and nucleic acid amplification tests and culture. So that is something that is coming. Now you have the National TB Prevalence Study, which came out. We briefly discussed this last year also. There are certain implications, so I am going back to it. The report is of one of the biggest, I should be saying that it is the biggest, prevalence study done for TB anywhere in the world. And that study gave us very good, results there. And the results actually showed something positive for Kerala, that, our prevalence is the lowest in the country. And in fact, you have places like Delhi and UP and all, which have 5 times our prevalence. So, we are much successful in this regard, and in the way we have managed TB in the past, which has shown results now. So we should all pat ourselves on our back for all the achievements that have come. So there was a lot of fear during the RMDCP era that, because of the intermittent regime and all, we would have a major crisis. But, we did successfully with that regime itself. And it's actually parts of India, like certain cities, I'll not take names and blame anybody, but there are certain cities where they were reluctant to go with the government programs, where they would always prescribe private drugs, where you have a huge crisis today. Now, certain assumptions that we made in the past in the RMDCP era and in formulating our program now had to change. And these had to change because, if you look at it, the assumptions we made is that first thing is that if you identify people symptomatic, you will cover most of the TB, because most patients with TB have symptoms. So symptom screening is a good way to find out whether you should test a person for TB or not. The second assumption we made in our program to do it is that most patients do come to hospital some point or another. So if you don't have to go to homes of patients, active case finding may not be required for TB. you can actually diagnose based on people coming to hospitals and actively screening those people. And the third assumption we made is that most infectious cases can be diagnosed by smear microscopy. Those who are negative on microscopy are non-infectious. So all these assumptions have gone out of the window. Today, with the National Prevalence Study and such prevalence study, other parts of the world, we have found that 40% of TB patients have no symptoms at all. So diagnosed TB patients who are culture positive, who are infectious, in the prevalence study in India, 40% of them have absolutely no symptoms. And this terminology called subclinical TB is now being used for this group of patients. And they also found that these subclinical TB, they are infectious and they do spread the disease. So if we go by symptom screening, we will miss 40% of the people in the TB in the community and they would continue spread TB. And when we are talking of TB elimination and all, we cannot afford to miss 40% of the infectious cases of TB. The second finding from the study was that significant proportion of patients who have symptoms, I mean, we told of 40% who don't have symptoms, but even when they have symptoms, they don't go to a doctor or a hospital. And at the national level, it is almost 64%. So only 36% of patients go to a doctor when they have symptoms of TB. In Kerala, we are much better off. So it's only 45% who don't go to a doctor even after they develop symptoms of TB. But even in Kerala, almost half the patients do not seek care even when they have symptoms of TB, which is a very disturbing thing. And the third finding was that about 42% of patients can be diagnosed only if X-ray screening is done. So if you don't do X-ray, you will miss 42% of TB. So X-ray has become even more precious with the release of our National TB Prevalence Study report. So the worry is that would you miss cases of TB? So are we missing cases of TB? So if you take, for example, a typical tuberculosis unit in Kerala, in a quarter, you have about 100 cases. So assuming that there are 100 cases in that area, so those are all the cases, the 100 cases that you have. And in that, among those 100 cases, when you look at it, the patients who have symptoms of TB, it's only about 60. So only about 60% of them have symptoms. So if you're going by symptom screening, only these 60 will actually be identified as TB. നമ്മൾ സ്ഥിരം പറയുന്ന സ്ലോഗൻസ് ഉണ്ടല്ലോ, cough more than 2 weeks, get tested, or fever more than 2 weeks to get tested. So if you do these slogans, CME and all, I mean the IEC and all properly, that will cover only 60% of your TB patients. Now, among those 60 in the TU who actually have symptoms, in Kerala, only half of them actually seek care. So out of the 60, only 30 will come to a hospital for care. So we started with 100% in a TU, 60 have symptoms, 30 actually come for care. Among the 30 who come for care, only half of them come to government hospitals. So that is what the prevalence study showed, about 49% each and 2% going to other places, other systems and all. So out of 30, only 15 will come to the government sector. So if we in the government sector, you and me, if we sit together and wait for patients to come to us to diagnose and control TB, eliminate TB in the community, that strategy is not going to work. And even among the people who come, we often do miss cases, and then that's the final number that we have. So at the end of the day, we might only have about 10 to 15% of TB being diagnosed. So this strategy is not good enough. We need to look beyond that. So the first thing is that you need X-ray screening so that you don't wait only for the symptomatics. At the next level, you need good IEC and active case finding to force everybody who has symptoms and everybody who has X-ray lesion to come and seek care. And then you need full private sector involvement, where in Kerala we have been very good, but many parts of India still struggle. So, that is also needed. And then finally, we need training and monitoring, training of all the doctors and health staff, and periodic monitoring to ensure that we all keep to discipline and that we don't miss any case at all. So only if we go through this whole thing and we cover everything, we will actually make a significant impact in TB. Now, this is a study that one of the KGMOA members in Kottayam, Dr. Matthew, is doing, and Matthew's study brought out some very interesting results. So if you look at these results, he looked at 4 different populations here: the urban, tribal, rural, and coastal. And what you see here is that when you look at, say, for example, if you look at the green rural population, um, a significant, good proportion of them go to the government, but even a good, reasonable proportion go to the private sectors. And then they go from private to government and from government to private, and they keep going either way, going up and down, changing sectors, changing doctors, going on and on and on. And for all the TB patients finally to get diagnosed, and in some of the cases, you need at least 6 doctors or 6 institutions to see the patient. In the private sector also, often you need 5 patients to see the patient. So what is significant is even among tribal population, even among coastal population, a good proportion do go to the private sector. So it's not that, the private sector is just limited to the urban population or to the richer population. So everybody, all sets of population do reach the private sector, and it keeps going between government and private. And there is so much of it's very complicated health seeking behavior, and we need to keep this in consideration when we do our planning. The other thing is we discuss this fact of subclinical TB. I'm sorry, spelling mistake is this subclinical TB. So people who don't have symptoms at all and they have TB and they continue to spread TB, how do we actually manage them? So you need to invest in mobile X-ray units, handheld X-ray units, use computer-aided diagnosis. You may need more technologies like CT, bronchoscopies, and all, active case finding strategies have to be modified. So somebody is enjoying drawing pictures on my screen. So I hope those lines will go off as I keep moving forward. Anyway, so case finding strategies have to be modified to cover for these subclinical TB cases. And some new biomarkers, promising biomarkers are coming, which we really need to consider so that we can diagnose them. Now, one of the success stories, again, from the government sector in Tamil Nadu is these X-ray vans, So the man with the brown shirt standing there is the district TB officer of Coimbatore district, a very brilliant man, hardworking man. These X-ray vans for Tamil Nadu, which Tamil Nadu has now about 50 of them, were mainly designed personally by him. He went all the way to Bangalore to the manufacturer, told them their specification needs and all. And if you look at the van carefully, there is a canopy to take care of the heat. There is a generator to take care of electricity needs. There is a television which will keep IEC messages and people busy while they're waiting for the X-ray and all that. And inside the van also looks like a 5-star hospital with the digital X-ray cartridges, which can be put into artificial intelligence and diagnosis can be made. Now, artificial intelligence and computer diagnosis coming in a big way. And you should realize that this company, Cure AI, is a company in India, led by a Malayali, and our own old KGMOA member and later WHO consultant, Dr. Shibu Vijayan, is now working for this company. And this company actually is the best in the world. In fact, I should say that. And they are covering so many countries in the world. So, I mean, I put my own patient into the software. It is available 2 weeks free of cost. So if anybody is interested, you can just subscribe. And for 2 weeks, they will allow you to put in your X-rays free of cost, and you can look at the readings and all. It will come like this. It will mark the area which is abnormal, will tell you what are the abnormalities there. So here it says there is a cavity, there is consolidation, and all those things. So those things, the software tell you what it is, and it will help you pick up lesions which you might miss if you're in a hurry. So that is something to consider. Now, at the end of the day, we traditionally have been using a lot of tests for diagnosing TB. The list is not complete. There are even more tests which can be done for TB. But as dedicated professionals, we should actually inform our other colleagues that not all these tests are good. So tuberculin and quantiferon gold are good, but their purpose is different. Tests like ESR, serology, PCR should not be done at all. ADA is a good test in certain scenarios, but the go-to tests today are the nucleic acid amplification test and the liquid culture. Of course, other tests like pathology and radiology have a major role, but yeah. So this is how you have to tell your colleagues that this is how we actually diagnose TB. Now, today, like we discussed in the last year also, this year also, we are also managing TB infection. So for diagnosing infection, you need a different kind of test. So I said the quantiferon gold and tuberculin. Tuberculin is not really available in India. Standardized tuberculin is not available. Whatever goes in the name of tuberculin in India is non-standardized thing, which you should not be using. But then any of these tests, is the government recommends that you can use either of this. And many states in India are using whatever tuberculin is available, because their numbers are so huge that they can't meet the cost of quantiferon gold. But our committee in Kerala insisted that we need a quality test. So we were testing with the quantiferon gold, which now we will move to the new antigen called the CYTB. Now, the point to remember here is that all these tests are tests for TB infection. You should not use these tests for the diagnosis of active TB disease or even to rule out active TB disease. So if your patient is coming with symptoms or if you have a radiological lesion or something, don't do any of these tests. These tests should be done in people who are normal, who don't have X-ray lesions, who don't have symptoms and all that. There you are testing them to start them on TB infection treatment. So this new test CYTB, we did discuss this last year also, very specific antigens like ESAT6 and CFP10. Now, government has procured at national level. We were telling Pulivarne. Finally, it has actually reached Kerala, and it has been supplied to the district TB centers. And very soon we'll start testing. I think the reluctance is that we have lost skills of testing. Intradermal skin testing skills have been lost, and we need to retrain our people to start testing again. So the test is already, the antigen is already available. Our district TB centers will soon start offering it. Again, informing you that this is not for diagnosing TB disease, this is for diagnosing TB infection. Because there are practical issues, like you have other tests called Ultra, which is a very sensitive test but can give you a lot of false positives. If you send a sample to the private sector, many of the private sector labs do Ultra. So your result cannot be accepted when the patient comes to us for provision of drugs like bedaquiline. When you have a specific result like very low detected in CB-NAT and rifampicin resistance, you have to repeat that because the certainty of rifampicin resistance is not the same. Applies to true NAT. Called, count is 10 raised, and you should always remember that between LPA and root, if there is a difference. And we should understand that when it's audible still, Vipin, am I audible? Because I got a warning that my net was, net was a bit faulty. Okay, thank you. So it actually is Mycobacterium tuberculosis complex, which is detected, which includes BCG, bovis, and all that. You must have read stories about, animals developing TB in the zoo and all. So elephants in TB, elephants in Kerala developing TB. So if you test all of them with this, it will come as MTB detected, which could be due to bovis. It could be due to human bacteria also. Moving on to treatment, the treatment part, like I said, the new guidelines have come, which have actually put in a different way of treating. So the drug sensitivity TB treatment remains same, 2 months of HRZD, 15 weeks. So it's a couple of weeks less than 6 months. And then you have the H monopoly resistance regime, which is where INH is replaced with levofloxacin, and you don't have an intensive phase continuation phase. You give the same drugs for 6 months. In certain cases, you might extend to 9 months or 12 months. And then you have the new regime, BPAL-M regime, which is the first go-to regime when the patient has rifampicin resistance. And if that is not possible, you still have a shorter regime, which is also different from what we were using earlier, because we had ethionamide in this regime, and that has been replaced by linezolid now for 2 months. And then you have the traditional longer regime, which still applies. A modified longer regime may be required in patients who are not eligible for any of these earlier regimes. Our results in treating MDR-TB have been very good with the newer drugs. So, this stops at 2019. So I gave you the latest figures from the TB India 2024 for 2023 results. And you can see that about 75% success in the shorter regime and 73% success in the longer MDR regime, which was unimaginable for specialists like me about 10 years back. If somebody told me that they can get 75% cure in MDR TB, I would have laughed at them. But then these success rates are coming at national level. Kerala rates are even better than this, so we are doing even better than this, with some of the cohorts having almost 85% success in MDR patients and XDR patients. Now, the challenge is that, are we detecting all our MDR? So this is Kerala statistics from the TB India 2024. So if you look at it superficially, we would appear very happy because, we have only 1% of our cases having MDR and 2% of them having INH resistance. But then we know for sure from studies that I have done in Trivandrum and Kollam and all that, INH resistance in Kerala was to the tune of 7%. Of course, national level, it is 13%. In Kerala, I was expecting 7%, but we are getting only 2%. So what is going wrong there? So there, when you look at the numbers, the first line LPA should be done for all your TB patients and look for INH. But in 2024 report, at that time in Kerala, only around 8,000 were tested when we had almost like 23,000 cases. So the point is only 1/3 of our cases are getting tested. The reasons are many, but unless and until we test. So when they were tested, among the population who were tested, 6% had INH resistance. So, you have to extrapolate that. Maybe would that percentage have remained at 6%? If we had tested all our patients, 20,000 plus patients, then, we would have had almost 1,200 INH resistance. So are we missing those cases? This is very important because if you don't treat INH resistance with the right regime, those people are likely to die. In terms of TB preventive therapy, we have discussed this a lot in the past in KGMOA forum itself. So I'll not go too much into detail. I'll only say that the two main points here are that we are moving the testing from IGRA to CYTB for adults more than, for the adult population. The children will still continue to be tested with IGRA. I have spoken at national level based on the request from our pediatricians that CYTB should be allowed for children. Actually, DCA has approved it for children. The program has to do it, and they are having a meeting on 26th. Possibly, we'll hear something further on that. The regimes, initially we had the 3HP regime, which is a 12-dose, 3-month regime with INH and rifampicin, 3 months of INH and rifamycin, which is a Kerala-only regime which we were giving to adolescents and children. And the 6 months of INH we were giving in certain groups. But now we have added 1 month of INH rifampicin to our HIV patients, 4 months of rifamycin for patients who cannot take INH, 6 months of levofloxacin for patients who have contacts of, not patients. These are all subjects. Patients don't get these regimes. It is contacts and infected people who get the regime. So this is for contacts of MDR, TB and all that. The last time the analysis has been done long back. We have not done any new analysis, but the last time when we did that, our completion rates were good and very, very few cases were breaking down. But of late, there is some disturbing trend that, uptake is going down in certain districts of Kerala. So we need to push again for that. Now, moving on to what is new, which is coming up new. So the Americans and the Europeans have come out with a practice guideline, which was released in December 2024. And this particular guideline now recommends 4 months of treatment with a new regime with INH rifampicin, pyrazinamide, and moxifloxacin for drug-sensitive TB. And for children, it is INH rifampicin, pyrazinamide, and ethambutol. But again, non-serious forms of children, you need to give only 4 months of treatment. So if a PG is asked a question, what is the minimum duration of treatment for TB? Until recently, the answer was 6 months. But now WHO and many other agencies like US FDA, the American Thoracic Society, the European Respiratory Society, all recommend 4 months of treatment. So the minimum treatment of TB has come down to 4 months. And of course, they recommend the BPAL and the BPAL-M regime. For India, we only have the BPAL-M regime. The BPAL regime, it's not there. I'll not go into details there. And in the innovation workshop yesterday, 2 days back, I was listening at Delhi about the desire that many places now they're looking for even a 1 month regime with all the new drugs which are coming in. So the people are not happy even with reducing it to 4 months. They want to reduce it further. And hopefully our patients will get the benefit of all these innovations which are coming. Now, the last bit of it is, what are the issues that we need to address? So there are certain issues which need to be tackled, and we'll just look at some of those issues. So one is nomenclature. So you all are aware that from the revised National TB program, we have moved to the national National TB elimination program. Often people make mistake and they say it's a National TB eradication program. So as technical experts and as professionals, all of us should be very careful about these terminologies. Don't get mixed up between elimination, eradication, and things like that. Be clear that it's an elimination program. But then when you say elimination program, it doesn't mean that we are out to eliminate TB. So come back to that. So there are various stages. We were earlier with the control program. Now we are looking at elimination of disease. There are many other things to do also, including eradication and extinction, which may not be possible for TB at all. So we don't talk of eradication in TB at all. Don't use the terminology. There are certain aspects. I have no time to discuss that today, but that we are not at that level. We are only at elimination of disease. And even elimination of disease is a faraway goal. It's not that we can do it now. So when you reach, less than 100 per million or less than 10 per lakh, then you start working towards pre-elimination. So currently at Kerala, we are at 60 per lakh, and India is somewhere around 200 per lakh. So we are nowhere even towards working towards pre-elimination, leave alone elimination. So when you reach 10 per million or 1 per lakh, then you say that you have reached pre-elimination. And then afterwards, then you start working towards elimination after you have reached pre-elimination. Pre-elimination 1 per lakh. Currently, Kerala is at 60 per lakh. So, we have a long way to go, And then after that only you start talking of elimination, which is 1 per million or 0.1 per lakh. So elimination is even further off. We are still further away from pre-elimination. We have still not even reached the stage where we work towards pre-elimination. So the program says it's National TB Elimination Program, but elimination is a target which is very far away. Then what are we discussing? What are we aiming for? we are actually aiming to end TB. So end TB is a different terminology. If you remember the slogan also talks of ending TB. And for ending TB, you have targets as compared to 2015. You're supposed to reduce mortality by 95% by 2035, incidence by 90% by 2035, which are very tough targets. I mean, to this NTB targets itself are very tough. They are nowhere near elimination, but these targets are tough and we are working towards those targets. So remember that we are working towards meeting the NTB targets. Now, the targets, when we reach them and all, is a different issue, which will not be discussed today. And to reach that, you need a lot of innovative things to be done. You need to have a reduction of 10% per year by 2025, till 2025, 10% per year, which 2025 we have already reached. And then further again at 17% per year, you have to have a reduction. So after 25, the sleep stove has to be even faster by bringing in so many new technology, including a vaccine, which we don't have. None of the vaccines have come up in a good way for us. So many things which are still not available with us. World over, the progress has not been very encouraging. So by 2025, you're supposed to reduce incidence by 50%. By 2023, the 24 report gives you 2023 data. You had reduced only by 8.3%. You are supposed to reduce mortality by 75%. You are reduced only by 23% by 2023. Zero catastrophic cause was supposed to happen in 2015, 2016, and even 2023, still half the patients have catastrophic cause. So which means that we are further away. Now, in terms of that, at global level, you can see that India has a reduction of around 10 to 19%, which is quite good for a big country like India. If you look at certain other countries, including the USA, it's only stable. It could not reduce. And, Canada actually had a worsening. So some of these countries had a worsening in terms of incidence. Even our neighborhood countries like Bangladesh and Pakistan were only stable. They could not reduce their incidence at all. And these countries are now going to struggle because many of them are dependent a lot on US aid, whereas our country is independent of that because our country's TB budget is almost fully met by the government today. So, US government stopping funding, US aid stopping funding is not going to affect India. So India is better off in that way. These countries have not done well, Pakistan, Bangladesh, Myanmar and all that, and they will even be worse hit because US aid support may stop for them. In terms of death also, India had a reasonable reduction of 6 to 19%. Whereas if you look at the US and all had an increase in death, probably after COVID hit them hard and, so that has actually occurred. Again, if you look at Pakistan, death could not be reduced. I mean, they're only stable. So, which means that, we have been doing better than many of the other countries, but we could have done more. If you compare with China, we are not done as well as China. So that is how it goes. Now, if you look at decline in Kerala, so our projection from the state TV cell shows that we had a very good decline, much better than the national level. 6.5% annual decline happened. But you should understand that even 6.5 is not enough for us to reach the targets. You needed a 10% decline till 2025. So we have had a good decline. We did well, but so both the private sector sale and the government sale or use of drugs have come down, which indicates a good trend. But then this is before COVID, and COVID also hit Kerala hard. So it came like that. In the midst of all these things, we have had these tragic cases, many of them like that, So all over Kerala, you feel sad when 14-year-old tribal girls die of TB, So despite giving them good care in Government Medical College Thrissur, the fact is that they come with such extensive disease. We have had young girls dying of TB. We had a pregnant woman dying of TB. We had other people, young girls dying of young boys dying of TB. So that makes us sad. Why should people die of TB? You and I would believe that nobody should die of TB. I mean, why should somebody die of TB when you're giving the best drugs free, when you're giving the best diagnostics free? Why should somebody die of TB? But you should see that this young girl's family took her home. They stopped treatment. They went from Thrissur to Palakkad, where they started her on magic treatment. All these things happening in Kerala. And finally, the girl died, despite the district collector and so many other important people trying to save this girl's life. All of us collectively failed, and this young girl died. Quite tragic and made me very sad. You see a lot of deaths, but when young people die, you feel even more sad. Now, the health department did take action. They went to the village, they did a symptom screening for all the people, did an ad for all those people who had symptomatic, yet no TB could really be diagnosed there. So no, again, the fact is that, you go to a tribal area, similar efforts done multiple times in many tribal areas in Kerala, but you don't diagnose many cases. The National TB Prevalence Study has shown that there is so much of TB in tribals. So we should be picking up so much of TB when you go to a tribal area. That doesn't happen. So what was actually needed? You actually needed to screen everybody with X-ray. So we have had cases, tribal patient. I can give you another example of a young tribal girl who did not die, who actually survived. When she was admitted in the ward in Thrissur, I asked my PGs, did you screen the family? So the mother and father were standing with her. So they said they are, my PG said, we asked for symptoms, they don't have symptoms. So immediately asked, did you take X-ray? So the PG had not taken X-ray. So the resident actually asked for X-ray. And when the X-ray was taken, the father had bilateral upper lobe lesion. So then I told you take a sputum, and I told the father to give a sputum. He said, I have no cough, I have no sputum. So then I kind of, said that I'm going to do a bronchoscopy. I'm going to put a tube through your nose into your chest and draw out the sputum. Then the man got frightened and said, let me try. I'll try to get sputum out. And sputum came and it was MTB detected very high, which means that the health-seeking behavior is often different in certain populations. They don't recognize their cough or they don't have cough or they don't recognize cough and they don't bring out sputum and all that. So if X-ray was taken, maybe we would have picked up more TB. And you need to cover everywhere. When you go to a tribal village, many of the sick people disappear from the village. They are in the forest. So you need a strategy, maybe a handheld X-ray machine, which goes even into the forest and takes X-rays. Maybe a good tool, which is readily available. One of my favorite persons, I've worked with her. I have done research projects with her, Dr. Soumya Swaminathan, who is one of the most famous women in India today, who says that the same thing which I mentioned earlier, the man not having cough and having X-ray lesions, subclinical TB is the reason why TB continues to spread. She makes a point there because in your tribal villages, there might be so many people like this who have symptoms, who don't have symptoms at all, but then they have TB and they're continuing to spread TB and we don't even know about it. And when we go there and screen only with symptom screening and do NAT for those symptomatics, we will never pick up the TB also. Now, one of the, things which made me a bit sad 3 days back was Dr. Soumya was speaking in Delhi, and she was talking about death in vulnerable population. And the example she gave was of Kerala and this house that she had visited in Wayanad district, where a young lady had died of TB, leaving behind two or three young children, whom the grandmother now has to take care of. So I was a bit surprised because, generally when at national meetings, presentations are made and Kerala is being mentioned, Kerala is always mentioned as a success story. Now, it's the first time in my life that I'm going to a national meeting. I'm hearing an example where Kerala, you had a death in a young person in a tribal area and we could not really do anything about it, which actually means that at least in our vulnerable population, we need to do a better job. Now, when you look at the national statistics, again, another thing which is a bit worrying is that nationally, of all the patients that we treat in India, drug-sensitive TB, about 3.6% of our TB die. Whereas when you take Kerala, the Kerala statistics say that 8.4% of our TB patients, drug-sensitive TB, die, which means that our death rate in Kerala for drug-sensitive TB is more than double the national average. Of course, the example, the excuse often given is that maybe other countries in North India are fudging their data, maybe their data is wrong. But the fact is that that is not enough to explain this, because in Kerala also we had lower rates much earlier, 4% and all. When I was working in the health service department, it was like 3-4%. It kept on going up and up and up. It's gone up now to 8.4%, which means that even don't compare with anybody else. You compare with ourselves itself, our rates, the trend is a disturbing trend, which means that we need to address the issue. So even at 8.4%, we really don't seem to have a perfect strategy for it. Whereas our neighboring state, Tamil Nadu, which has a mortality rate of 5.6%, they got very angry that, the government got angry that they had 5.6% mortality, and they immediately brought out a new strategy, Tamil Nadu's new strategy to reduce death in Tamil Nadu, which was a major success story now being projected all over India. So it's called TN-KET. I'm not able to pronounce that properly. Kasnoi obviously is TB. Kasnoi Ripilla Thittam or something like that. So which is TN-NET, which actually has reduced deaths in Tamil Nadu. So, certain governments in the country are addressing death and we also need to learn. So it's an unfortunate situation that, many other states in India now are learning from Tamil Nadu. Generally, they were all learning from Kerala. So why are we not able to do something similar to Tamil Nadu? Because Tamil Nadu invested a lot in X-ray machines, so they have like 50 portable X-ray vans going and taking X-rays in remote areas, and they also take CBNAT inside that van. So that takes diagnosis to a next level. They admit all the patients who are identified as likely to die and give them special care. Whereas in Kerala, we don't have any facilities for admitting patients. You take Kerala today, from south, Pulanarkota has beds for TB patients. Then you go up north to Kollam, where you have Karunapalli, which has a TB hospital. And then you keep going north, then probably Mulangantattakava and then Pariyaram. Many districts in Kerala don't have any TB beds at all. And we should remember there was a scenario like when I was in the health service department and working in Chalakudi Government Hospital, I had a 14-bedded TB ward in my hospital, which used to take care of all those tribals. And all those tribals were my patients, and I was happy with them. They were happy with me. And 14-bed patients could be admitted, TB patients, any time in Chalakudi, and we could actually take care of their special needs. Now, today, that is not possible, and you're seeing that patients from Etlapara, Malakapara, and all are dying because their diagnosis is going very late. So we need to think on how we can do. Also, the fact that you have patients with no family support, homeless people come to Thrissur Medical College at any point in the ward, there'll be 5, 6 people who are homeless, who are admitted there for food and care and everything. Most of them begging in Guruvayur. The moment they are healthy enough, they will abscond from the hospital, stop their medication, and go back to Guruvayur. Just imagine all those pilgrims in Guruvayur, one of the biggest pilgrim centers in Kerala, and all of them exposed to patients who are irregular on treatment and who are infectious. So that is a reality we have. Now, there are other issues also that Kerala would face, increasing proportion of extra-pulmonary TB. We have one of the highest rates in the country at around 35-40%. We have higher proportion of comorbidities. Our diabetes rates are the highest in the country at around 32%. Our patients recognize ADR better, or maybe they have more ADR. So that is also something we need to address. NTM definitely will keep coming up in Kerala as we reduce TB. There are patients with low blood levels, but we send our patients to Chennai for testing. We still haven't been able to manage our own testing facility. Patients needing surgery in Delhi and all, they get a lot of Delhi, Bombay and all, they get a lot of surgery done. But in Kerala, to get a surgery done for a TB patient, a pneumonectomy or a lobectomy or a decortication is extremely difficult. And then, of course, the last biggest question is IP care for TB patients, which again, unlike the Tamil Nadu model, we are not able to replicate because we don't have facilities at all. Now, national strategy plan is there for managing, reducing TB at national level at mortality. Certain points of them we can think of in Kerala, which is to implement a differentiated care strategy, which is what Tamil Nadu did. But then that would mean that at every level, at district level, taluk level, and even maybe at lower level, CSC, medical college, every level, you will need beds. There are medical colleges in Kerala which don't have TB beds. So, at all level, you need beds. Otherwise, people will continue to die. Assessment and management of undernutrition. There's a new, very important study called the ration study, which was done in Jharkhand, which showed that when you give proper nutrition to TB patients and their family members, you can reduce TB by a great extent. So other factors like anemia and everything should be managed. Minimum time for diagnosis. I mean, I got a call. I will not name the district. A district where the private doctor got into trouble because the non-medical coordinator for private public mix went to the hospital and complained that this doctor is sending samples outside to the private labs, for commercial purposes. Whereas this lady always sends samples to the district TB center. It's only very now and then that the hospital lab outsources some other place without her knowing. And because of that, she sent samples only to a district TB center. And one patient's result, a gene expert, which should come in 2 hours, the result came only in time. And by then, the patient was in the ICU with on the ventilator, and treatment was delayed. And she was complaining that, how can gene expert take 1 week for results to come? So this is something turnaround times have to reduce mortality. And we all need to sit together like maternal mortality is assessed. You need to sit down and assess TB mortality, why it happened, what are the reasons, what could we have done better. While I'm talking of all the issues in Kerala, we have multiple success stories in Kerala. Our MDR, XDR rates are the best in the country. We have the best private sector involvement and medical college involvement in the country. Our state difficult to treat clinic are example for rest of the country. People emulate that, and we have very good doctors involved in that. Many of them are there in this webinar, and they actually give good input. So just to tell you, there are difficult to treat clinics at district level and state level. If you have cases which cannot be managed at your hospital level, you can refer the cases there online. The district TB center will facilitate that process, and experts from all over the state will come together and give you opinion on that, pulmonary TB and extra-pulmonary TB. And the lower numbers in Kerala make it easier for us, So That is an advantage for us. So MDR TB center in Mumbai has like 1,500 patients, whereas MDR TB center in Kerala has only around 100 patients. So it's easier for us. There was a time when interaction was better. I knew every MDR TB patient in the Trivandrum site. We have very good political and administrative commitment, which is not there in many states. And our local government involvement and people involvement is extremely good, which is a success story again for us. So we showed the success during COVID. So during COVID, when states like Bihar, 80% reduction in detection happened, Kerala could keep it down to only around 10%. So we also had a reduction, but then we were much better off than many states in India. And our local government involvement has been a major success story. The Rakesh and team have put in excellent work, and that is also a story which is being followed in many other parts of India. So I conclude by saying that we had rapid advances in the diagnosis of TB and treatment of TB, but we all need to update regularly, otherwise we'll be left behind, And we have better understanding of disease epidemiology, which allows us to plan our strategies better. There are certain Kerala specific issues that we need to study and solve, and you are the best people to do it for the state. Thank you for the patient listening. I'm sure that we will all commit towards ending TB. We'll convince our governments, the central, state, and the local governments to invest in TB, and all together we will all deliver and we will end TB. Thank you for the patient listening. Preeta, I sort of exceeded by around 10 minutes than what I planned. So I think we're to 55 minutes. Sorry for taking that much extra time. Thank you.
Thank you, sir. Thank you so much. കുറച്ച് ക്വസ്റ്റ്യൻസ് ചാറ്റ് ബോക്സിൽ വന്നിട്ടുണ്ടെന്ന് തോന്നുന്നു. ഡോക്ടർ വിപിൻ.
Okay, so question says if TrueNat and CBNAT have low rates of pickup. Okay, I'll clarify. I just was trying to say that TrueNat and CBNAT have much higher pickup rates as compared to pick up only 50% of the TB cases in pulmonary TB. The NATs put together, I mean, one of the NATs, if you do it, you pick up about 80% of cases. That means that 80% is much better than the 50% that the smear can pick up for you. But you should understand that it will not be 100%. There will be still cases which you have to diagnose on your chest X-ray. Now, when it comes to lymph node TB, the NAT can pick up 80% of the cases. But when it comes to pleural effusion, NAT can pick up only around 17% of cases. But if in pleural effusion, if you do smear, the pickup rate is only around 5-10%. So, in whichever the situation you take it, system, that is why it is preferred over the smear. Okay, chest X-ray. TB is, one of the facts of time we lost our skills to diagnose TB on X-ray. So of late, what happens is many of us are not confident enough to diagnose TB on X-rays. In colleges, we have the advantage, X-ray lesion kanda. ഞാൻ ഓടിപ്പോയി എൻ്റെ കൊളീഗ്സിൻ്റെ അടുത്ത് ഡിസ്കസ് ചെയ്യാം നമുക്ക് ATT സ്റ്റാർട്ട് ചെയ്യണോ വേണ്ടത്. When you're alone, it's quite difficult because of the medical legal issues and all that. You may not be able to. അവിടെയാണ് ഈ പറഞ്ഞ technology comes in and the technology actually helps you. So technology, but then you should understand that the artificial intelligence computer diagnosis of a patient, it will only tell you that there is abnormality. It will not tell you it's a TB or not. The decision finally will rest with you. So cavity ഉണ്ടെന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ക്യാവിറ്റി അവർ പറഞ്ഞ ക്യാവിറ്റി ആണോ, ആ പേഷ്യന്റ് പഴയ ക്യാവിറ്റി ആണോ, പുതിയ ക്യാവിറ്റി ആണോ, മരുന്ന് കൊടുക്കണോ വേണ്ടേ, ഇതെല്ലാം നമ്മൾ തന്നെ തീരുമാനിക്കണം. മെഷീൻ വിൽ നോട്ട് ടേക്ക് എനി മെഡിക്കൽ ലീഗൽ റെസ്പോൺസിബിലിറ്റി. That will still last with us. So again, you may have to certain cases, you may have to consult with the district TB center, with the difficult treat clinics and all that. So that will actually go in. Now, AFP scanty and TrueNat negative. So I would definitely work up that patient. So, scanty AFP can occur in many situations. AFP can go false positive also. In today's era, the NAT is supposed to be the better test. So if the AFP is positive and if your NAT is negative, you have to evaluate the patient for non-tuberculous mycobacteria and other causes. Of course, if clinically everything fits with the TB diagnosis, the NAT also can be negative in in like 1% of the TB cases. So at the end of the day, you could start ATT, but most probably you will work up for other causes. You will not go with that scanty smear result. I hope I have answered those questions. If you need more clarification, you can definitely ask on that. Shinobi, you want to add something?
ഓ ഇല്ല സാർ, ഒന്നുമില്ല. താങ്ക് യു സാർ. സാർ, ഈ എക്സ്റേ പറഞ്ഞത് എങ്ങനെയാ സാറേ? നമ്മൾ ഈ കോണ്ടാക്ടിന് എല്ലാവർക്കും എക്സ്റേ എടുക്കുന്നതാണ് ഉദ്ദേശിച്ചത്, അതോ അതിന്റെ ഒരു ഫ്രീക്വൻസി എങ്ങനെയാ സാറേ?
എക്സ്റേ എടുക്കും. ഷിനോബി, ഞാൻ ഉദ്ദേശിച്ചത് എന്താന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഇപ്പൊ നമ്മളെ സ്റ്റേറ്റിൽ 4 എക്സ്റേ മെഷീൻ വന്നിട്ടുണ്ട്. അപ്പൊ ആ 4 എക്സ്റേ വന്നത് നമ്മൾ ഉപയോഗിക്കുന്നത് അത് ഉദ്ദേശിച്ച രീതിയിലല്ല. നമ്മളൊരു വൾണറബിൾ ഏരിയയിലോ ഒരു ട്രൈബൽ ഏരിയയിലോ അല്ലെങ്കിൽ ഒരു സ്ലമ്മിലോ പോയി എക്സ്റേ സ്ക്രീനിങ് ചെയ്യണമെന്നുണ്ടെങ്കിൽ ഇപ്പം സ്റ്റേറ്റിൽ പലയിടത്തും ചെയ്യണം എന്താന്ന് പറഞ്ഞാൽ സിംറ്റംസ് ചോദിച്ചിട്ട് സിംറ്റം ഉള്ളവർക്ക് എക്സ്റേ എടുക്കുകയാണ്. അങ്ങനെയല്ല അത് ഉദ്ദേശിച്ചിരിക്കണം. എക്സ്റേ സിംറ്റമിനെക്കാളും ബെറ്റർ ആണെന്നാണ് ഉദ്ദേശിക്കുന്നത്. അപ്പൊ ഒരു ട്രൈബൽ ഏരിയയിൽ പോയി കഴിഞ്ഞാൽ ആദ്യം എടുക്കേണ്ട എക്സ്റേ ആണ്, പിന്നെയാണ് സിംറ്റം ചോദിക്കേണ്ടത്. അപ്പൊ നേരത്തെ പിടിച്ച് എല്ലാവർക്കും എക്സ്റേ എടുക്കും. നൗ ഇറ്റ്സ് ഡിഫിക്കൽട്ട് ബിക്കോസ് ഒരു ദിവസം അയാൾ മെനക്കെട്ട് ഹാൻഡൽഡ് എക്സ്റേയും കൊണ്ടുപോയി എടുത്തു കഴിഞ്ഞാൽ അത് ഒരു 200 എക്സ്റേ മാക്സിമം എടുക്കാൻ പറ്റും രാവിലെ തൊട്ട് വൈകിട്ട് വരെ അയാൾ ജോലി ചെയ്ത് കഴിഞ്ഞാൽ. അപ്പൊ ഒരു ട്രൈബൽ ഏരിയയിലൊക്കെ ആണെങ്കിൽ 200 ആണെങ്കിൽ ചിലപ്പോൾ ഒരു വില്ലേജ് നമുക്ക് കവർ ചെയ്യാൻ പറ്റും. പക്ഷെ ഒരു അർബൻ ഏരിയയിലൊക്കെ പോയി സ്ലമ്മിലൊക്കെ പോയി കഴിഞ്ഞാൽ 200 പറഞ്ഞാൽ ഒന്നും ആവില്ല. അപ്പം പല വിസിറ്റ് പോകേണ്ടി വരും. അങ്ങനെയൊക്കെയുള്ള ഇഷ്യൂസ് ഉണ്ട്. ഐ എം ടോട്ടലി അണ്ടർസ്റ്റാൻഡ് ദ ഡിഫിക്കൽറ്റി, ബട്ട് ദാറ്റ് ഇസ് ദ ബെസ്റ്റ് വേ ഓഫ് പിക്കിംഗ് അപ്പ്. ഇപ്പം ഒരു നമ്മൾ പഴയ നിങ്ങൾക്ക് കോട്ടയത്തുള്ള ഇഷ്യൂ, ഓൾഡ് ഏജ് ഹോമിൽ പലർക്കും TB ഉണ്ടോ ഇല്ലയെന്ന് സംശയമുണ്ട്. എല്ലാം പ്രായമുള്ളവരാ, സ്പ്യൂട്ടം എക്സ്പെക്ടറേറ്റ് ചെയ്യില്ല. അവിടെ നമ്മൾ പണ്ട് ചെയ്ത സിംറ്റംസ് നോക്കിയിട്ട് നാറ്റ് നോക്കുക എന്നാണ് ചെയ്തിരുന്നത്. അതിനി മാറ്റാനുള്ള സമയമായി. ഒരു ഓൾഡ് ഏജ് ഹോമിൽ പോവുകയാണെങ്കിൽ ഹാൻഡ് ഹെൽഡ് എക്സ്റേയും കൊണ്ടുപോയി നേരെ പോയി എല്ലാ എൽഡർലി ആളുടെ എക്സ്റേ എടുക്കുക. ലീഷൻ ഉള്ളവർക്ക് സ്മിയർ നാറ്റ് നോക്കുക. നാറ്റ് നെഗറ്റീവ് ആണെങ്കിൽ TB ആണോ ഇല്ലേ എന്നുള്ള കൺസിഡർ ചെയ്യുക. ചിലർ ഇപ്പൊ നാറ്റ് നെഗറ്റീവ് ആണെങ്കിൽ CT എടുക്കേണ്ടി വരാം, ചിലർക്ക് ബ്രോങ്കോസ്കോപ്പി ചെയ്യേണ്ടി വരാം, അങ്ങനെയൊക്കെ ചെയ്യേണ്ടി വരാം. അപ്പൊ അങ്ങനെ ഈ പറഞ്ഞ ടെക്നോളജി വരുമ്പോൾ നമുക്ക് ജോലിയും കൂടും. ഒരു സാധനം ലീഷൻ കണ്ടു കഴിഞ്ഞാൽ പിന്നെ അത് വെറുതെ വിടാൻ പറ്റില്ല. അപ്പം പിന്നെ മാലിൻസി ആവാം, ചിലപ്പം TB മിസ് ചെയ്യണതാവാം. അപ്പൊ അങ്ങനെ ജോലിയും കൂടും, CT സ്കാനിന്റെ ആവശ്യം കൂടും, ബ്രോങ്കോസ്കോപ്പിയുടെ ആവശ്യം കൂടും. ബട്ട് സ്റ്റിൽ ദാറ്റ് ഇസ് ദ ന്യൂ ടെക്നോളജി. ദാറ്റ് ഇസ് ഹൗ യു ആർ സപ്പോസ്ഡ് ടു ഡു ഇറ്റ്. Any other questions? Otherwise, you can wind up over to the organizers.
Shinobi, you can propose a vote of thanks.
Okay. Respected KGMOA state and district leaders, academic cell leaders, Sanjeev sir and dear members. ആദ്യമേ തന്നെ സഞ്ജീവ് സാറിന് നമ്മുടെ ഒരു ക്ഷണം സ്വീകരിച്ച് ഈ വേൾഡ് TB ഡേക്കും സാറ് നമുക്ക് TB യെ പറ്റി വളരെ നല്ലൊരു ക്ലാസ്, പ്രത്യേകിച്ച് അപ്ഡേറ്റ്സിനെ പറ്റി എടുത്തു തന്ന സാറിന് KGMOയുടെ പേരിലുള്ള പ്രത്യേക നന്ദി അറിയിക്കുകയാണ്. സാറിന് വളരെ തിരക്കുണ്ടായിട്ടും സാറ് ഈ ദിവസങ്ങളിൽ സാറിന് ഒത്തിരി ടോക്കിൽ സാറിന്റെ പേരൊക്കെ ഉണ്ടെങ്കിലും സാറ് നമ്മുടെ ക്ഷണം സ്വീകരിക്കുകയും നമുക്ക് നല്ല ക്ലാസ് എടുത്തുന്നത് സാറിന് പ്രത്യേകം നന്ദി പറയുന്നു. അതുപോലെ തന്നെ നമ്മുടെ KGMOയുടെ സ്റ്റേറ്റ് ഡിസ്ട്രിക്ട് ലീഡേഴ്സിനും അക്കാഡമിക് സെല്ലിലെ ലീഡേഴ്സിനും ഇത് ഓർഗനൈസ് ചെയ്തതിന് പ്രത്യേകം നന്ദി പറയുന്നു. പിന്നെ നമ്മുടെ ഇതിൽ ഏകദേശം 150ഓളം മെമ്പേഴ്സ് ആക്റ്റീവായിട്ട് പങ്കെടുത്തു. അവർക്കെല്ലാവർക്കും പ്രത്യേകം നന്ദി പറയുന്നു. താങ്ക് യു.